Dr. Mohammad Mahdi Ansari.
Yes, hello, Assalamu alaikum. Hello, can you guys hear me? Hello, can you guys hear me?
Yes, we can.
All right, okay, great. So the next two lectures, I've been asked to summarize in 10 minutes of acute limb ischemia and critical limb ischemia. So because both the talks were mine, I decided to make them both together for the sake of time and talk about both acute limb and critical limb ischemia and talk about intervention strategies on a case-based approach. And I was asked to be innovative by Dr. Bashir, and thank you very much for this invitation. So I decided to be innovative. These are my disclosures. So when we talk about limb ischemia, acute or chronic, the most important thing is we have to be prepared towards this. And when we talk about any strategy, it starts with our preparation, our planning. What are the device utilization? What are the staffing considerations? And what is the load of the thrombus burden in an acute setting? And then whatever strategies you want to take towards that, it comes to point that why I'm going to talk about the innovative strategy, because everybody knows about in our part when we do these kinds of procedures what acute limb is and what critical limb ischemia is. But the issue is when the human being is cornered into the box, what would be the innovative strategy which we want to talk about? So when we talk about the wave of these patients coming in, particularly when renal function is compromised and there are other strategies that you wanted to adopt, that things come into CT scans most of the time with the amount of contrast is given, not a strategy, particularly in a program that I have. And one thing that really picked up is radial interventions. And the question is it possible? Okay, you can do simple, straightforward lesions, but the big question mark comes in when you talk about innovative strategies or acute limb. Is it possible to do radial wise? And we're going to lay emphasis and we're going to talk about those cases and we're going to talk about critical limb ischemia as well in an acute and a chronic setup from radial adventures. We talk about essentials of the cath lab and we go towards these cases. Actually, these are the long cases. So any strategy adaptation towards, if you look at the guidelines and if you look at the adaptation for the devices, but what it doesn't take into consideration, the timing of these cases. So we risk stratify patients, we look at the urgent emergent scenario, and we talk about, okay, what our documentation could be. A lot of things divide on around medical management when the patient comes into the emergency room, because not every program is able to take these patients right away to the cath lab, which is essential. So a lot depends on better anticoagulation strategy till the cath lab is ready for these patients to be transferred out. Because I have collected data across the world in many countries where when patients show up at night, they are started on anticoagulation for an early morning case, and limbs are pretty forgiving when you want to give them time towards recovery. So our planning conclusion was actually when we were stuck in a COVID scenario and all these cases were showing up, and the kind of groins that we get in Texas over here, we decided to come up with a strategy if we can do more radial cases to have same-day discharges. And this would decrease our dependability on the supply chain. It would decrease our dependability upon the staff issues. And there are limitations, but we came up with a strategy how we can counter the limitations. And particularly this happened with the innovative strategies we want to pick up during the COVID era because of the severe limitations and because of the bed assessment. There was one time when our hospital was working at 135% capacity with a federal tent in the back and a state tent in the front of the hospital, all completely booked without no bed available, and the ER wait was 24 hours. So that's what we had to come up with. So yes, all these complex diseases, it depends on the strategies. And these are actually the locations where we have done access for these cases. And the prime strategy for any critical limb or acute limb ischemia is your access point. So femoral, direct SFA or profunda, popliteal, tibial stakes. Dr. Zakir just talked about multiple tibial stakes, plantar vessels, radial brachial access, axillary access, transapical, transcaval, antegrade, retrograde. These are the accesses that we have done in case of or peripheral arterial disease dilemmas, and multiple vessels at the same site we have been able to access for both acute and critical limb ischemia. We have data from the prime registry. For the sake of time, just to make it in time, I'll go a little quick. that actually talk about all access points when you come across both acute limb and critical limb ischemia. More data on this was on the critical side on the chronic limb ischemia section. And if you see on the timing of different axes, various axes were utilized and different axes show different timelines, but most of them showed that it's a safe entity. Yes, of course, the tibial were more safer as compared to the question when it came up, but when you talk about the contrast usage and the radiation usage as well, it was much better. Similarly, in the radial side, we did our study where we concluded if this strategy is applied, you would still have contrast and radiation much more saving. And the question is, you're coming down way from the radial to do these cases. So why would it be less? Because it's not easy to do these cases this way, but there is always a learning curve, but it's possible to do. And in the end, when the learning curve is sufficient, what happens is your strategy improves and your contrast utilization and your radiation utilization also improves. When we talk about the advantages, acute limb going towards distal or doing thrombectomy or going atherectomy, out of the box thinking there are devices. There are a couple of devices for atherectomy which are available. There's one device for thrombectomy that you have to adjust with your catheters. And there are now stents also coming in that can be utilized. But there are the balloons that we currently use that we go the same balloons from radial to peripheral depending on the shaft line. And when we did the surveys, it showed both economically and the convenience factor. When you talk about critical limb ischemia or acute limb ischemia strategy, the patient preferred it, the lab staff preferred it, the hospital and the economics of the insurance way, everybody preferred it when it comes to the both economic side or the convenience side to the patients. So I'll jump towards the case loaded to discuss both these strategies about both critical limb ischemia and acute limb ischemia from radial approach. And cost savings we talked about. So this is our first case, a 58-year-old man with right lower extremity non-healing wound. This is a more chronic setup of a CLI. We have CFA and SFA problem with this patient. And actually, this is a picture that actually I'm showing. I'm coming north from radial, where my catheter is parked actually in the iliac. And what I'm trying to do, there's no common femoral artery over there. And I'm trying to cross from above, trying to construct the common femoral artery. After constructing the common femoral artery, going down into the SFA and opening the common femoral into SFA, just doing balloon atherectomy and scoring balloon and able to create a channel and subsequently restoring flow in this patient Ischemia knot. And this is the end of the case because you see the bladder is completely full. You are showing that the amount of contrast that was used in this patient. This is another case, 72-year-old female, aortoiliac occlusive disease and a distal toe gangrene. Again, this is a chronic situation, multiple comorbidities in a patient. It deemed poor surgical candidates and was referred for a peripheral angiogram and intervention. And this is what we get. Now, is radial the answer to all such cases? No, it's not. But this patient has no other avenues. This patient was being sent to hospice because the surgeon doesn't want to operate. It was a huge groin. There is no vessel over there. No anesthesia wants to put this patient to sleep, and this is what you get. But in these circumstances, radial becomes a door, making it possible for you to approach for these cases. And whenever we have cases like this, we actually sit down and have what we call the PAD team meeting with our vascular surgeons and our CT surgeons. And we approach from the radial side, opened up the channel, went down. We were able to see the common femoral, then access the groin, and went from above and below with our catheters and our wires, create a channel. And this is what we were able to create towards the end, creating the entire aorta down with the iliacs and to the common femorals. The entire procedure was not done from just the radial approach, but radial became the doorstep for us to doing these kind of cases. A 68-year-old, this is our third case. He presented with right leg pain after undergoing bilateral aortofem bypass and right femoral popliteal bypass surgery. He also had comorbidities of smoking and PAD, arterial Dopplers and light regression revealed acute limb ischemia. So this is the case that we didn't have any approach to go from the groin, and we approached from the radial, and this is what we got. The patient actually had a graft procedure done before, and on the right side, the limb was ischemic, and there was no way for me to go to the groin because of the presence of this fungating mass ulcerated thing over there. So we came down radial. We were able to cross down from the radial using the machete technique. We were able to cross down utilizing the curve of the regular glide wire with our catheter, and then afterwards using a bilateral catheter to just do thrombectomy, hooking up to the penumbra catheter. And after that, we went on to create the flow. Let me see if we can show the flow over there. And luckily, and then leaving these patients afterward because it was slow flow. But if you leave these patients on a 24-hour of heparin drip and bring the patient back to the lab and repeat the Dopplers, you will be restoring clear flow with the burden going down. There is ECOS catheter utilization in these patients. It's also possible, but ECOS doesn't reach the real tip of the patient. So it's like really partial, but sufficient to help the patient in these circumstances when you do not have any other approach. One other thing people might argue, you can go tibial in such patients, but the only issue that happens with the limb ischemia, the burden of the thrombus dilation is all directed towards south. So it really doesn't suit well in acute limb setting, just doing the tibial approach. It always have to be a combination. But radial, because you're coming from the north, really helps out. Another case, 75-year-old man presented with bilateral lower extremity pain, coronary artery disease, CABG, multiple comorbidities, left common and SFA. And this is the reason. These are the cases that actually help out that you can do bilateral, because this is the professor wanted to leave the next day, and issue was bilateral calcification, severe claudication symptoms, severe pain in the foot. We treated one side, did atherectomy, went on to the other side. This is the burr of the atherectomy device CSI. We're utilizing up from the radial down towards the calcification panel, and we were able to create flow in both the legs. And patients subsequently walked out of the hospital, being discharged the same day, being treated with bilateral. This was the end result of the vessel that has severe calcification. We were able to create a lumen just coming up from north. Our fifth case, 85-year-old man presented with abdominal pain, generalized weakness, and lower extremity weakness. Now, this patient came with bilateral acute limb ischemia. And usually from the groin issues, how these patients are treated, you do one side, and then you wait and get the patient to the unit, bring back the other side. This is the patient we treated on both the limbs on the same side. And this is what we did. We came down radial, there was thrombus burden in the axillary artery. We opened that, came down common femoral, down to the SFA. If you look at the third picture towards the right, opening up in the popliteal, going down, doing thrombectomy with our catheters hooked up the penumbra, passing the wire in. This is utilizing the vector catheter for the thrombectomy, hooking up to the penumbra on the left side. On the right side, you say flow starting to flow in. And then we crossed up with the sheet back, wire back, crossed it into the other side, crossed the other side into it, cleaned up that limb, and we were able to do bilateral. Yes, one limiting factor is you cannot reach down to the tibia, but luckily the issues were in above the knee. And once we opened that up, there was clear flow going down. This is also showing on the right side in the manner we were conducting the thrombectomy. So this is the picture from one side to other, going down, opening up the tibia. We were able to go towards the mid of the tibia, suck out the clot, and was able to also do balloon angioplasty. And on the right side, you could say clear vessel flow coming down. Our sixth case, again, bilateral extremity signs of hypoperfusion, went in, treated one side, went to the other side, put a stent in from the patient from the north, and were able to treat the patient. Last case, just to share this last case, a lot of chronic critical limb ischemia patients that come in are post-surgical patients. And this is the kind of scenario we ran into. The high risk of surgical case cannot go to the groin, created the groin again, went down. And what we were able to do in this patient, after doing our atherectomy, we were able to clean up the vessel, and we were able to actually stent across the previous placed graft. So we were, instead of opening up the graft, we were able to open up the main SFA vessel and pushing this Masago stent through into regenerating the vessel over there and let the glass flow through. And we were able to treat the patient. So yes, it is doable. It's a curve. It helps in those patients that you need. It's an innovative strategy. And it is essential to know it is included in our toolbox for patients like this. And we talk about a whole collaborative village involvement because we work very closely with our CT surgeons and our vascular surgeons. And innovation is the cornerstone of human success. And it's only the out-of-box thinking that we have to think and help our patients. And that's how things come into play. One quick note on the complications for the sake of time. There are safety considerations which are device-related, management-related, and human error-related. But the whole thing about this thing is the worst-case scenario could be access-related, which could be just taken care of by holding the groin. Yes, if there are perfs and other things, these are a difficult scenario, but most of the devices, capacity in these things are lacking to get that severe effect that one could worry about. So it's a possible, it's a start. Let's see what the other device companies would come up with to help us in the future. Thank you very much. If there's any questions, I would welcome that.
Thank you very much.
I hope I made it in time.
Dr. Ansari, do you have any questions from the panelists?
Hello, I'm Amber Malik from Lahore. I have a question on acute limb ischemia. You mentioned a few cases and you said you had some slow flow and you said it'll get better with a drip of heparin, I heard. So what about your use of TPA or some such thing with acute limb ischemia? And a drip of about 24 to 48 hours, which we quite frequently use. And the next thing is, how safe is it in the elderly? We've had a few intracerebral bleeds and, you know, some of the staff goes hands off, let's not use it.
No, I completely agree. So there are two different things over here. One is why I like to use heparin and tirofiban. I only use that when after completing the case sometimes, I see that after multiple ballooning, okay, the flow is there, but there is slow flow over there. I have come up with a strategy of utilizing what I call the Texas Tech solution, which is utilization of graph mix with nitrite, nitro, and verapamil and amlodipine combination that I use with heparin. And what I do is I continue that drip for 24 hours and I repeat an angiogram to bring them back to see what the difference is. And I see that the flow greatly improves. This is the next paper that I will be publishing. This is after revascularization. I usually utilize TPA in cases prior to intervention when I see these cases with heavy thrombus burden, but I've stopped utilizing TPA directly with catheters. What I use is, I use ECOS catheters, which is a modality we have available over here, which are actually catheters with ultrasonic waves in it. It utilizes TPA at a lesser dose directly into the clot and utilizing ultrasonic wave technology to really mesh the clot over there. I utilize it, my cutoff point is, I have gone even to a 90-year-old where I've utilized it. I half the dose in case of using 1 ml per hour. I go to 0.5 ml per hour, and I have a 12-hour protocol for that I utilize. And after 12 hours, instead of waiting 24 hours, I do 12 hours in an elderly if I'm worried about bleeding. And so far, thank God, I've been lucky with it. But yes, at other centers, I've heard about the bleeding issues. It's just that you have to pick and choose your patients who you think would go ahead. It is a risky thing, but with ultrasonic waves, I have much success and less bleeding issues.
Mac, Suhail here. How far you go down by radial access? Do you have long enough sheets? What is the longest length you have? Or do you have the shafts, balloon shafts, or the stent staff available, the length of it? And do you have any problem, for example, if you are crossing a complicated CTO by radial, do you lose that torque or that control over your wires and catheters compared to coming from retrograde?
So yeah, this is absolutely a very good question, Sohail. So the issue over here is this. So when we were initially starting it, when we were starting the program, it was a learning curve. I was not that great. I was struggling, but I had to try. I had to do it. Luckily, learning through this, I became better. The issue over here is that with the best of the devices, you can reach to the mid, or if a patient is smaller length, to the mid-distal tibia. Of course, going to the foot is very challenging, and that has been the issue. So the acute limbs, if you're talking about complete limb occlusion, that would be very challenging. If you're coming down just radial, you have to use tibial access as well. But with the devices currently that we have available with 170 shaft balloons, you can come to the mid tibia. That's where you can receive, and that's what I show in those cases that I've done so far. The main issue is the good thing that has happened because of the utilization and coming up with the radial strategy. Multiple vendors have jumped into this, coming up with new devices. We didn't have this before. Now we have 200 length catheters, 200 length shaft balloons. We have better balloons. We have 450 length wires. We have atherectomy devices, thrombectomy devices. Now devices are coming in this direction. But when we started, there was no atherectomy device, and the first one came. Now the second is coming. There's still no thrombectomy device. I utilize other catheters from my rack that I created. So right now, still there is a need of more device coming in. But if you want to start the program and you say, where can I reach safely? Yes, you can reach to distal popliteal, mid tibia easily. If you want to go above that, it has to be a combination strategy with the pedal approach as well.
Hey, Assalamu alaikum, Mac Salman here. How's it going?
Hello, Salman. Nice to see you.
Good to see you. That was an excellent talk, and I think you've been here. I mean, you've seen the setup in Pakistan. Obviously, right now you're in the Punjab of the US, you're in Texas, you've seen the situation there. I think one of the problems here is not only awareness amongst the patients, but also limitation resources. And I think one of the points I often make is that a lot of these procedures, especially below the knee ischemia, can perhaps be done even using coronary equipment. So we don't always need the heavy duty stuff. Obviously, what your state of the art, and mashallah, you've reached a point where you can do a lot of these complex cases in a short period of time. So that was a comment. And the question is, what is your advice for our colleagues here who want to start a program? And I specifically want you to talk about, just briefly, about the requirements of the team approach, the fact that you actually need wound care follow-up, and it's more than just the procedure, right? So you can do the procedure, but it's a matter of educating the patient and also tending to the wound so that that procedure has a successful outcome.
So my advice to them would be two things. Number one is, a lot of things I did not learn. For example, to be a better wound care person, I'm a cardiologist. And actually, I had no interest in wounds, but I had interest in PAD. And when I saw what the difference I can make, and I used to send to wound care people, and I started learning how to do wound care, and I collaborated with them. So there's a possibility to learn everything, and we want to learn everything, and we want to help our patients. So my recommendation would be there's two things. Number one, what I call self-development and what I call program development. Self-development would be that you cherry pick cases to do. You see a simple lesion, you use a simple sheet, come down with a wire, use your coronary balloon, and try to make the difference with just simple cases. You start doing simple cases, and this is how your approach would be to learn this and get better to it. I did not learn this in my fellowship. I started doing it while being an attending. So you start with small cases and you gather information and you learn this. That's one thing. When we talk about the program development, that is more collaborative approach. So you want to get in touch with your diabetes specialist, your medicine specialist, your wound care person, your podiatrist, your CT surgeons, your vascular surgeons, your rheumatologists, your renal specialists, and you want to create a village of individuals, like I call it the PAD village, where everybody has an input and everybody has this collaborative, comprehensive center. When I started, there was nothing over here 5 years ago, and I created this over here. Now we have a whole PAD center of excellence with 30 specialists across 15 specialties that we were able to create over here. So it's doable, it's possible, and it's also baby steps to start with, but it's absolutely possible. And if I can do it over here, then honestly, I don't have any what you call surhab ke par. I think anybody can do that,
Wonderful, thank you. And again, congratulations on all that you've achieved.
I think you have combined both lectures, so I will request our next speaker, who is a very famous in Pakistan on WhatsApp group, that is Salman Arai, who will be speaking about no stent zone, CFA, SFA, and Profunda femoris bifurcation popliteal artery, how to treat. Welcome, Salman Arai.
No, not just Pakistan, he's also famous here.
Thank you very much. I'm famous in different places for different reasons. But anyway, first of all, I want to thank the organizers for having me here today, and then I want to thank the panelists, and I also want to thank the online panelists. Some of them I've met in the past. This is the wrong talk. This is for the next session. Can you please go back to the session 1, please? The CFA talk. जो से पिछला session था ना उसमें. So I'm going to talk about something a little bit less drastic. I mean, acute limb ischemia obviously is a life-threatening, if it's a limb-threatening situation, it's a bit of an emergency. What I'm going to talk about is a bit more about the common femoral artery. And Bashir, when he was setting up the program, wanted me to talk about the no stent zones. Pointer. Thank you. I thought it would be too much to talk about both the femoral and the popliteal. But I want to talk about the CFA today, and hopefully we'll touch on the popliteal in the question sessions. Okay, so endovascular therapy is now the treatment of choice for several lesion subsets, especially in claudicants or patients who have complications after procedures. The advantages of endovascular include lower morbidity and mortality compared to surgery. Oftentimes the clinical benefits are very similar. Long-term patency rates also tend to be similar. Thank you. However, it is still considered to be off limits for certain areas within the vasculature, and chief amongst those is the common femoral arteries. So we have seen more people attempt common femoral, both amongst the surgeons and IR, and especially the cardiologists who've been doing it for many years. It's still considered a no stent zone, and oftentimes a lot of consternation over that. So there's a growing trend towards endovascular first for the occlusive femoral artery disease. It's driven by developments in technology, and we have different treatment modalities. And we have several treatment options, and I'll just go down the list. You have plain and or cutting balloon angioplasty that's tried and tested, but the restenosis rates are high. There's drug-eluting balloon angioplasty, atherectomy of various kinds. There's excisional, there's orbital, there's laser atherectomy, intravascular lithotripsy, stents, and a combination of the above. And usually this has to be done on a case-by-case basis. The Achilles heel of CFA stenting or angioplasty, however, is data and lack thereof, because this has not been done in a systematic fashion. Every center does its own way. The lack of randomized studies, except for one, which I'll talk about. There's a lack of standardized treatment algorithms within the literature. Part of it has to do with the fact that the technology is evolving and the protocols are evolving, and there's limited long-term efficacy data, though our experience suggests that focal CFA lesions tend to do quite well with percutaneous treatment. And one of the things is this conceived notion that we have that atherectomy or endarterectomy is still the gold standard. And while that's true, we have to recognize that it does not come without its complications. So if you take all complications, this is from a large meta-analysis done actually by surgeons in a surgical journal, any complications is about 15%, infection is up to 18%, and there's paresthesia is greater than 6%. Paresthesias are often not documented, and there's in fact a mortality of 3% approximately. So the one trial that actually was published, this was published in JACC Interventions in 2019, it's done in France. It's called the TECO trial. This was surgery versus endovascular treatment of de novo CFA disease. Most patients ended up getting a stent. About 2/3 were self-expanding stents, 1/3 were balloon expandable. There were 117 patients randomized to surgery or endovascular and followed for about 2 years. And they looked at primary morbidity, mortality outcomes for the 30 days and then clinical follow-up. And what they found was that when you looked at primary events at the time of the index procedure, there were more complications with surgery compared to endovascular, 26 versus 12.5%. The length of stay was also shorter within the surgical group, within the endovascular group, though in the comments they wrote that this is because one of the reasons it was 3 days for endovascular is because that's what's mandated by practice there. In our practice, if I do a common femoral stent, patients often go home the same day. So for me, it would be 1 versus 6 days. And it's similar patency. So you can see on the charts to the side that over 2 years, survival, target lesion revascularization, target extremity revascularization, and patency were all quite similar. So this makes the argument that percutaneous is a good approach and perhaps should be used more widely for CFA disease. Now, here's some anatomic and technical considerations. The CFA is almost, in some ways, the challenge is the same of dealing with the left main artery. It's a short bifurcating vessel, and you want to preserve both branches. And more often than not, you want to preserve the profunda because that supplies all the collaterals to the below knee compartment. Oftentimes, the disease is confluent with proximal or distal plaque, so you're treating more than just the segment. On the side, there's a scheme that was actually devised by the surgeons to describe the 4 types of CFA disease. This does not have any clinical or prognostic implications. However, just to tell you that type B is less common, and more commonly either patients fall into type A or type C, where you have extension of disease both above and below. There's a high degree of external compression and stress. There's always this concern about leaving stents there and the risk of fracture. And CFA is often the site for medium to large bore access. So many times you have to use the groin for procedures in the patient's future. All right, so this is my approach to CFA disease. This is just a summarization of my experience over the past decade or so. First thing is physiologic evaluation. Is the patient asymptomatic or not? Asymptomatic patients do not need to be treated. Obviously, this is not life-threatening. If you have rest ABIs, sometimes they're normal. You have to do rest and exercise ABIs. Sometimes you have to try and see if the patient has atypical claudication. So patients who perhaps present with hip pain, but then they have a normal hip X-ray and the MRI is normal, and they still keep complaining of hip pain, and they have a history of CAD or PAD think about atypical claudication. After the physiologic evaluation, you can do an anatomic evaluation. Many times this involves, review of a well-done ultrasound. If the patient has had a CTA, or you can order a CTA, because oftentimes the plaque is posterior, you can see that on a CTA. And if there are any prior angiograms. So for me, example, the patient has had a coronary procedure in the past, I'll go back and look at the angiogram, because more often than not, we do take, if it's femoral access, a CFA angiogram. SFA occlusion with good surgical target, I think surgery is the best option for that. I think while I like to do SFA stenting, and that is the sort of mainstay of what I do for my critical limb ischemia patients, I think for claudicants, you get better long-term results if you have surgery. So if there is an SFA occlusion with a good distal target, I often will convince the patients to go for surgery. And most of the patients understand the rationale and will consider it. If, however, the patient, for whatever reason, is now ended up in the cath lab, then I try to use my best practices for doing angioplasty alone, using the data from the anatomic evaluation and from the angiogram. We'll then plan for either debulking or using something like shockwave to modify the plaque and then go ahead and do DCB angioplasty. So if the disease is focal or if it's non-calcific disease, I might consider something like Silverhawk, debulk. If it's more diffuse calcific disease, I'll use something like IVL, and I'd like to finish with the appropriately sized DCB angioplasty and then follow the patient clinically. Make sure there's no flow-limiting dissection. However, if the PTA is failed, either immediately or long-term, because of a dissection, immediate recoil, or long-term ISR, then stent is an option. And my stent of choice for this location is a Supera, which is braided nitinol stent. Just a quick word about the Supera stent. I think this is what sort of made me more confident about stenting the common femoral artery. It's a nitinol stent. Unlike other stents, the one on the top, for example, is laser cut. What the Supera is, it's a braided tube. So there are 6 strands of nitinol that are woven into a stent. This gives the stent a lot of flexibility, which is the property of the nitinol, but it also gives it a lot of radial strength, as you can see on the side there. And here's one of our cases in a patient who actually ended up with critical limb ischemia, and this is on a follow-up angiogram, and I actually had him flex his knee to show how the stent can actually flex with the knee without actually kinking or fracturing. And this patient, 6 years on, is doing quite well. In fact, he not only is doing well, he skis and plays tennis with his stents. All right, so I will end with a case presentation. This is a 78-year-old woman with progressive left lower extremity claudication, long-standing history of bilateral iliac and femoral disease, and this was actually done by one of the surgeons in town. This patient came to me for a second opinion at the recommendation of her cardiologist. Her resting ABI was a mildly abnormal 0.78 on the left, and which is why she was told that she did not have critical disease. However, we didn't do, or they did not do a walking ABI. I suspect it would have been lower. However, the ultrasound did show that she had patent SFA stents with monophasic waveforms, suggesting there was proximal disease, and there was eccentric plaque with elevated velocities within the common femoral artery. We convinced her, or we talked about going for an angiogram. This is what the angiogram showed. And on first pass, you can see the widely patent stents. You see that sort of focal napkin ring lesion in the common femoral artery. You can see the stents are patent. You can see the non-stented segment. And there's below knee disease. You have 2 vessel runoff, which you'll see right now. I do like to do a complete angiogram at the start of the procedure, because if I plan to intervene, I want to make sure that I'm leaving the runoff the same way as I found it. However, this is an angled view, and here you can see the disease is more extensive. So it's not only that moderate-looking lesion in the common femoral artery, but she actually has a tandem lesion up top with some post-natal dilatation in the external iliac artery. And so you can see that this is a sort of a tandem lesion multifocal disease which had been missed by ultrasound alone. So we went ahead and did angioplasty. One of the things I will do is maybe just use angioplasty first, then use a drug eluting balloon. The idea is to make sure that the vessel is compliant and I can get things open. And so this is angioplasty. This is our angioplasty result. Let me show you. There we go. Okay, so this looks quite good. And the next step actually is to use a drug-coated balloon, which we did in the external iliac. However, there is that sort of focal sort of haziness you see at the distal common femoral, and you can see that there actually seems to be a spiral dissection. So what I sometimes will do is do an intravascular ultrasound. In this case, what we did was a pullback gradient. So what I'll do is I'll leave the wire in, take maybe a 4 French catheter, and we do a pullback gradient. And interestingly, despite the good appearance of the vessel on angiography, there was actually about a 30 millimeter gradient across that location with the arrow. So we went ahead and decided to stent it. This is the stent. This is Supera being deployed. The deployment is a little, beyond the scope of this lecture. It's a little different, but you have to sort of shape or create the stent shape as you withdraw it. So you just can't withdraw the sheath. You have to actually stay in place and let the stent open up, and then you can decide how long or how short it's going to be. You can see the wire is positioned towards the popliteal, towards the profunda. There's post-dilation of this. This was a 6 millimeter Supera. There's post-dilation there with a 6 millimeter balloon. Then you take the wire and you pull the wire back and you basically reposition it within the SFA. And so just the way sometimes we do for like a Medina 100 bifurcation stent in the coronaries, you go ahead and do the pot in both directions. Here's a pot towards the SFA. And this is basically the final appearance. You can see the stent looks different. So the stent on top is a Supera. You can see the braided appearance. You can see there's some inconsistency in the cells. This will even out over time. But you can see the laser cut stent down below it, slight different appearance. This is the angiographic appearance, which looks quite pleasing. And again, we completely eliminated that 30-point gradient across the common femoral. Interestingly, there was no gradient across the external iliac lesion. Now, the patient did have some disease on the left side, so we brought her back in 2 months to treat that. But I just want to show you that in 2 months later, this is what the SFA and the iliacs looked like, and the patient had a very good result. Now, we've done cases where the Supera stent is longer than this, and we've actually gone through the cells of the stent itself to go up to the coronaries if need be for a CT or something like that. All right, so in conclusion, the CFA is traditionally considered to be a no-stent zone. However, there's emerging data to support an endovascular first approach. There's one randomized control trial that showed endovascular therapy to be equivalent to surgery in terms of patency with less peri-procedure morbidity. There's several treatment options for the CFA, but ultimately what we need is additional studies and more experience and perhaps a more standardized protocol with larger patient populations and longer follow-up. Thank you.
Just a comment, again, being an endovascular person, I still think that the end arterectomy remains the gold standard therapy. And the patency, I mean, is as high as 90% going all the way to 10 years. And the one trial that you showed where it shows the 15% perioperative morbidity or mortality, and in that study, the duration of the surgery was 2 hours. Nowadays, this surgery can be performed in about 30, 40 minutes. But I totally agree that the CFA treatment should be patient and the lesion specific. If you have an elderly guy who is not very active and high risk of groin infection, morbidly obese, then we should consider endovascular therapy. And then if it is a younger patient and you have a chip shot type A lesion, even in Europe, they're very aggressive. The TECO trial is a French study, so they, even in type C lesion, nowadays they're putting stents. But that's something that I would definitely not do. But again, if it is a young patient, active, lower risk of infection, I think end arterectomy is not a bad option.
No, so I just want to clarify. So this is not an argument against end arterectomy. It's an argument for percutaneous. And I think we have to move the science forward. So I think while it's true that's the gold standard, I think it's a gold standard because it was grandfathered in. And actually, I submit that if we had better done studies and longer studies, I think you'll find that the patency for stents also is quite good over the long period of time, especially more focal stents. But I agree with you that you have to look at the overall disease pattern and see what the patient presents with. But I don't think necessarily it's blasphemy to consider percutaneous approach for the appropriate lesion in the patient.
Can I make a short, in fact it's a question because it's something that we've always been taught and learned and propagate that CFA is a no stent zone. You seemed to have a lower threshold to put a stent in. Visually, it didn't look that bad. You put in an IVUS. I cannot put in an IVUS, right? So I would look at it and probably think. But the good thing that you taught is that there was a 30 millimeter gradient across this, which anybody can check actually. You put a catheter across it and you can check the gradient.
Correct.
So that is perhaps a good tip, that you don't have an IVUS, you just do that and see whether it requires a stent. However, we don't have a superior stent, right? So
correct. And I think, you know, again, and that's a caveat, the technological limitations. But the point was that, you know, angiography alone doesn't tell you about physiology. And this is a case that sort of highlighted the decision making. I think this was arguably maybe one of the less stenotic sort of post-angioplasty results. And ultimately, while I don't have hesitation putting in stents in, it's not my first choice. My first choice often is debulking and using IVL or maybe using a DCB. I think that does quite well too.
and the same applies to the popliteal, which is like the left main of the leg.
Popliteal is a little bit more complicated because oftentimes, sorry, just to finish that answer the comment, the popliteal oftentimes I don't necessarily treat isolated popliteal, though I guess if you have to, you can. The flexion zone is not behind the knee joint. So if there's a focal lesion behind the knee joint on the angiogram, that's okay. You can actually stent that. It's actually higher up in the adductor canal. So just like that one, the clip that I showed of the patient with the bent knee, the stress on the stent is much higher up, and people have been stenting it forever. All the femoral popliteal stents have done that. And that's where I think fractures are also more common. But I think the fact remains that the SFA restenosis rates tend to be very high. And you try and avoid using metal, and if you think that the patient is failing endovascular, I think surgery is a great option for that.
I think
Salman, I have one quick question.
Yes.
Okay, please.
Yeah, so I mean, are you using IVUS to size your superior stents in the common fem, given how important it is to be accurate with their sizing?
Yes, absolutely, because I actually had a terrible complication where we sized the stent based on angiography. It was a young female patient, and she came in with stent occlusion, and then we did thrombolytics, and then we brought her back, and the stent was actually floating. And I realized that I'd undersized the stent because what I probably put the stent in was actually thrombus or chronic thrombus. So since then, if I'm stenting, especially in the popliteal or the common femoral, I will either use, the poor man's IVUS, which is you can use a balloon and then just do a sort of what do you call it, the contrast pot, the puff of contrast. But given time, and because I work in an academic center, I almost always will use IVUS to size supera for the common femoral.
Thank you very much, Dr. Salman.